Thank you. All right, this is the special meeting of the North Dakota State Health Council dated December 16th, 2020. We have a special meeting today, which means we have an agenda that has been pre-published. We must abide by that agenda. There are topics on this agenda that might have some information associated with them that is not for public consumption due to privacy issues. So I prefer that as we talk about some of these issues that they be spoken about in generality and not specificity. If there's any need for specificity, we would have to adjourn to an executive session in order to address that. So please be mindful of that. Thank you. May I have a roll call vote or a roll call? So.
Good morning. Can everybody hear me?
Yes.
All right. Daryl Birch.
Here.
James Brusso. Jenny Deinstman.
Yes.
Mike Fedorchak. Tyler Lanoy.
Here.
Dwayne Poole.
Here.
Kristen Roars.
Here.
Tori Saylor. Dennis Wolf.
So we have 5 members, which does constitute a quorum. We expect Dr. Brousseau to join us as well. If anybody drops off or needs to drop off for a reason, please let us know ahead of time if you can, so that we understand that we're no longer at a quorum. So the first item on the special agenda was related to behavioral health analyst discipline and the telehealth percentages. Would Bobby Will please take the lead on that?
Yeah, good morning, Chairman Poole and members of the Health Council. On November 18th, I asked if you would consider adding the behavioral health analyst to our current behavioral health discipline list in our North Dakota Century Code 4312-3. And you asked some questions that I wasn't able to answer, so I do have some experts with us today, but they put together. So Clint, you can go ahead and put up the flyer. You did receive some documents from Donna, and there was a 1-page handout in that information. Today, Clint did have to split that up into 2 sections to fit it on our life-size platform. But Holly Johnson, who's a board-certified behavioral health analyst, also working at the Department of Human Services, the Life Skill Transition Center, and is a part of the governor's autistic task force. She put together this flyer so you could have an idea of how many behavioral health analysts that we do have in this state. She gave a representation, of course, on that upper right-hand corner of where the behavioral health analysts are located. And then, Clint, if you could go to the other section of the flyer. Holly also put together, you had asked what type of licensing was needed for a behavioral health analyst compared to the other disciplines. So she does have those listed out, and their dollar amount for school. So I am going to go ahead. I think she did a great job at presenting all of the information of questions that you had in November, but you could have additional ones. So I'm going to go ahead and let her answer any questions that you would have on the flyer. But before she answers the question, I'd like her to speak to one of your questions, and that was the amount of time or the number of patients that a behavioral health analyst can have. And she does address that at the bottom section of the 1-pager. And then Clint, it's actually at the bottom of the first slide. So Holly, I'm going to have you speak to the very bottom section about the time of a behavioral health analyst can spend with a patient, if you could go ahead and address that.
Yes, good morning, Chairman Poole and members of the Health Council. There's national data on what areas behavior analysts provide services in from our national credentialing board. And in that data, 74% of us serve people with autism spectrum disorders. And usually those are kids. And usually those kids are receiving anywhere from 5 to 40 hours a week of intense ABA services, either in home or in clinic, which is the direct one-to-one is usually performed by a behavior technician under the supervision of a board-certified behavior analyst. And so those technicians need 5% of their hours supervised each month, and the kids with autism should have 10% case supervision per month. And those are national guidelines put out by the Council of Autism Service Providers, or CASP. And so the reason that there's a limited number of caseload when delivering autism spectrum disorder services is because of that high intensity need, the supervision of the techs to make sure they're implementing the therapy right. And so our guidelines say for a full-time BCBA, anywhere from like 12 to 15 or 16 clients, depending on the intensity of services those clients are receiving. However, behavior analysts also serve a variety of other populations. For instance, my work with the Life Skills and Transition Center, I serve adults and children, but on a more consultative kind of service delivery. So I actually figured out my caseload for the state, and I have like 106 active people on my caseload. But that doesn't mean that every week or every month I'm seeing all 106 of them. Sometimes if there's a lot of problems with a service provider that they're having, it might be more intense, and then it might fade out to checking in every month, every quarter, just to make sure that behavior plans are running right. So really that caseload size of 15 is very specific to delivering intensive ABA or applied behavior analysis services to children with autism.
Thank you, Holly, for that. So Chairman Poole and members of the committee, do you have any questions on the behavioral health analysts or on the document?
Membership? Do you have any questions? Hearing none.
Actually, I do have one question. Thank you, Mr. Chair. Bobby or Holly, probably Holly has a better handle on this, but just understanding the demand for the role, can you just help us understand, you have numbers of how many we currently have in the state, but really how many more do we really need? I know that the answer is a lot, but if you can just give us a ballpark idea of where we're at for demand.
Yes, so our last autism task force meeting, there was a number shared for the North Dakota Medicaid ABA service department, and they had stated, I want to say like 887 children have been approved for ABA. And so I took that number and divided it by the 45 licensed behavior analysts we have in the state. And that would be just over 20, a caseload of 20 per behavior analyst. And I know that not all of us just provide services to autism, kids with autism. And so, for instance, with my division out of the Life Skills and Transition Center, we have 6 behavior analysts, 3 in Fargo, 2 in Grand Forks, 2 in Fargo, 2 in Grand Forks, 2 in Bismarck, and then me in Minot. And so our caseload number ranges from, 60 to over 106. And so that number that's specific to kids that I, have data for is even more than that. And so in order to ethically provide the services to those kids with autism, I feel like the behavior analyst caseload is stretched. It's the quality of service is probably lacking a little bit.
And maybe my better question would be, do we have an idea of is there a lot of positions posted across the state through private and public functions that are unmet? Are we struggling to recruit?
Yes. So my supervisor, Dr. Paul Colstow, he's posted our open positions. I think we have 2.5 open positions, and it takes a solid 2 to 3 years to recruit somebody for those positions. And that includes recruiting, which he did at me, also students who are then finishing their field work, and he grooms them into those positions to meet the qualifications.
Okay, that was very helpful. That was kind of that time frame. That was really what, just to know, like, yes, in the grand scope, this may be a tool that could help us recruit people into the state from outside, help narrow that window. So, okay,
yes.
Thank you.
And one other thing I wanted to mention too, like on the map, the health professional shortage area map, you can very clearly see where we're concentrated at. And I actually saw a position posted for Fargo schools looking for a board certified behavior analyst, and their salary was $64,000 to $79,000 a year. And I had heard there was a $15,000 sign-on bonus. Well, that makes me want to move to Fargo. And so I guess in my opinion, we're not going to recruit people to Central, Northern, Western North Dakota unless there's some kind of program like this to provide an incentive to go or stay in those places.
Excuse me for just a moment. Clint, if you're still listening, can you contact Dr. Brousseau? He can hear and see everything, but he is not able to speak and we can't see him through life size. Sorry, let's continue.
No, thank you, Holly. That answered my questions. I guess based on that information, I would be in favor of adding them to the loan repayment program.
We have a motion. Is there a second?
This is Daryl. I would so move.
You'll second?
Second.
A motion by Roars and a second by Birch. Dirt, is it okay for Dr. Brousseau to just text me his vote if that's?
Yeah, just as long as it's documented.
Okay. So Dr. Brousseau, if you decide to have a question or vote, text me until you can do so otherwise. So let's call for the vote then.
Daryl Birch,
Yes.
James Brousseau, Jenny Deinsman,
Yes.
Mike Fedorchak, Tyler Lanoy,
Yes.
Dwayne Poole,
Yes.
Kristen Roars,
Yes.
Tori Saylor, Dennis Wolf,
Dr. Brousseau sending a text to me at the moment, so.
Thank you.
We'll record that one after the fact, since there's already a passage of this. He voted yes. So, all right, motion to add the discipline passes. Second item on the agenda is a brief update on COVID response.
Hold on a second, Mr. Chair. So Bobby, how does that actually work? Does the department request the bill, or do you need to find legislative sponsorship, or?
Yep,
And
that's
that was
what I
actually,
was
sorry.
gonna say next. So this vote was to have us move that to legislative session. So Senator Roars, I was going to ask if you would sponsor or carry that bill. And I believe that Holly and the Autistic Task Force, they probably have someone else that they would want that they've been working with.
Yep. Yeah. So if they can just email me on the kroars@nd.gov, that'll be great. And I will take care of that.
And I do have the language for you, so I'll go ahead and email that. So yes. And as far as then the telehealth data update, I will actually be sharing that in future meetings. There's a lot of data that we're still pulling and sorting, but the main objective of this meeting was if we could have you guys vote on that as well to make a change in before legislative session. But when the telehealth task force group met, they did come to a consensus that they do not want to change any legislation. They do not want to change the century code for telehealth for the services allowed. And there are three main reasons where they really do want to keep face-to-face as much as possible. With the new slots being in the optional budget request, they just thought this wasn't the appropriate time. And we do have a significant number of applications already for behavioral health that we could be putting into slots. So we really don't need to be opening up that space. We did have a couple of meetings prior to our November meeting, but we were unfortunately not able to have that final meeting until after with everybody's COVID responsibilities. So that conclusion was made after that November 18th meeting. So we do not need to move forward with that agenda item, but I will provide telehealth data in the future. So that's all I have today.
Thanks, Bobby. I appreciated your memo on it, and I like the idea that you're focused on prioritization for now. So, anything else on behavioral health then, members? Nope. All right, let's move on to the second item then. Sorry, I got ahead of myself, Dirk.
No worries. Thank you very much, Chairman Poole, for the opportunity to give a brief update of what's been happening in the fight against COVID. I would say that we're at a much different position than we were last time we met. Obviously, our numbers in terms of cases, positivity, hospitalizations is all down. Some examples of that is our test positivity last week, December 7th through the 13th, was 6.56%, whereas from the 30th to the 6th, it was 8.48%. And so that just in the past few weeks is a 26% decrease. Same thing in terms of caseload. From December 7th through the 13th, there was a 2,705 new cases, where from November 30th to December 6th, there was 4,102 new cases. And so there was a 34% decrease in cases from that week. And that keeps following the trend that's happened since we put certain mitigation efforts in place. We did extend those mitigation efforts last week. And so my health officer order requiring face coverings to be worn in indoor businesses or indoor public settings, as well as outdoor public settings where physical distance can't be possible. I did extend that through January 18th. The reasoning behind that is we want to make sure that we have at least one incubation cycle past the holidays, past January 1st, to make sure that we have, in fact, kind of stabilize things and that mitigation is fully working. So that was kind of the logic of why I extended it to that date. In addition, Governor Burgum extended his executive order until January 8th, which limited capacity for bars, restaurants, and event venues. So that's been extended from, originally it was set to expire December 13th, which would have been this Monday, but it was amended to extend till January 8th. There is a press conference today, and so I know that we'll be probably talking about this some more, but that's where it was at as of this morning. The other mitigation effort that was in place previously is we did do a 4-week pause on high school winter sports and competitions. That was allowed to expire on the 13th, and so high school sports are back in action. The North Dakota High School Activities Association did update their spectator guidance to align with the statewide limits of large gathering with Indy Smart Restart. So we are excited about the mitigation efforts and the success they've had. We do believe they've had an impact in reducing the spread and getting our numbers back down. I would say that great job, North Dakota, but we can't let our guard down. I think we made a lot of good progress, but these things have happened in waves all across the United States. And if you look across the United States right now, it really is probably at its worst it's ever been. And so we're just in a unique, nice place in relation to where other states are at. In addition to—
Can I ask a question about that?
Of course.
Just comparative to other states. So I see on social media different graphs. Of course, they never have a source listed, so you don't know how to trust it and that kind of stuff. So just wondering, do we do comparison of state to state, that kind of stuff? Because you'll see, like right now, they'll show like North Dakota versus South Dakota following the exact same curve, obviously at a little bit different intervals there. So can we show that the mask, mitigation really was the causation and not just correlation?
Yeah, I mean, I would say that region, because they all had their significant spikes at the same time, and then they all had similar decreases, and that's what I'm talking about in terms of waves. I would say that we could probably show that when our mitigations went in place, we probably had a steeper dive than South Dakota, at least initially, to show that those mitigations did have an impact. But I would also say that with any disease, as it travels in waves, there is a threshold point where it starts sloping down. And I think that's what's happening probably universally across the mountain states in the Midwest. And so I would say that it might be a little bit of both. I would say that our mitigation did have an impact to slow the spread and start our curve maybe a little bit quicker. So our numbers are a little bit better than our neighboring states. And I think if you look around, that bears itself out in positivity and where our hospitalizations are going and all these other aspects. But I'm not ignorant to the fact that there is sloping down happening across our region.
I would add to that you also have the confounding effect in that response of the Thanksgiving events that happened, which may have mitigated some of your ability to align causation to those data curves. One of the things I would look at is the rate of change of slope of those curves. That's actually the equivalent to acceleration. If you're decelerating that curve, that's a real strong indicator of a positive response.
I'd agree. Other questions on mitigations? Because I want to move on. Go ahead.
The inoculation process, it's been started already. I'm starting to see pictures of North Dakotans sharing they're getting inoculated.
That was actually the next topic I wanted to jump into. Is that the big exciting news is that we do have vaccines in our state. As everybody is probably aware, Pfizer vaccine was approved over the weekend. We did receive 6,825 doses of that vaccine in North Dakota for the first allocation. We did decide, similar to other states, to allocate those doses to our referral hospitals, and our vaccine ethics committee did make a decision that even within phase 1A, there would be tiers. And so the tier 1A that would be receiving this vaccine very first would be those in the referral hospital that do have direct patient contact with COVID patients. And so that might be our critical care staff and physicians, our ER staff and physicians, kind of our primary care nursing. And so those kind of positions are targeted to get the COVID vaccine first this week. I know that Sanford, both in Fargo and in Bismarck, have quickly started doing vaccination on all their staff members. The other hospitals are ramping up throughout this week, and so it's an exciting time. I mean, it's this for us is really the path out. You know, there's no real path out of COVID-19 without vaccination. It hasn't been proven to work any other way other than vaccinations being the path out. And so we're excited that this happened. We're excited that it happened so quickly. And then even better news is the Moderna vaccine is up for review starting tomorrow. And so they'll go through the same process that the Pfizer vaccine went through over the course of this weekend. And we do expect them to also get approval from the FDA and the CDC for use of the vaccine. And we do have a estimated allotment of 13,000 doses of that we'll be receiving next week. And that'd be in addition to whatever allocation we receive of the Pfizer vaccine. So that would be sort of the next allocation that would be not only designed to more reinforce the allocation initially sent to referral hospitals. This would sort of be the time when we would turn on our federal pharmacy program and partnership to vaccinate long-term care facilities. We would start vaccinating the community in terms of like local public health, critical access hospital, tribal. And so we do expect with the amount of vaccine that we would be receiving from Pfizer and Moderna, that we would be able to rapidly go through that phase 1A group, which is the healthcare workers and long-term care staff and residents. And so we think that can happen within probably the first part of January. And then we'd be moving on to phase 1B.
So I'm going to take another time out here. Donna, could you have Clint reach out directly to Jim Brousseau and give him some assistance? He's been trying to contact the office to find somebody to help him get voice communications with us.
Okay, I will send Clint a message.
Can you send Clint his phone number, please?
I will sure look for it and see what I can do. Thank you.
Thank you. I'm sorry, Dirk, but Dr. Brousseau is somewhat frustrated in his inability to get connected like the rest of us are and participate.
I am wondering just if he clicked on the YouTube link instead of the meeting link. So that's, I guess I'd ask him if he did that, if he can hear me.
I sent him the phone number as well, and he didn't get through with the phone number either.
Well, then never mind.
I can do.
Any questions about the vaccines or anything along those lines that I can help attempt to answer?
Dirk, this is Jenny Dietzman. I'm just curious, are we working with the National Guard then to distribute those vaccines, or are they able to be doing those at the medical facilities, or are we using, just be curious to know how those are being
So you're asking how they're being delivered?
Yeah, delivered, right, yes.
Yeah. So fortunately enough, there's a couple ways that they could be delivered. The federal government themselves, if the allocation is large enough, can do a direct delivery to the provider. So for example, for Sanford, Bismarck, and in Fargo, they did receive direct delivery from the federal government for portions of their allocation. The Pfizer vaccine comes in packages of 975 doses. And so for some of the facilities, we had to break that down at the Department of Health, and then we would distribute it after we broke it down for them. The Moderna vaccine is even better in terms of the package and where it comes from. It only has packages of 100. And so this is sort of probably the vaccine that we're going to target for use in more rural areas, because then they can just send those packages of 100 direct to those facilities, and then any other things that need to be broken down further, that would happen at the Department of Health.
Also, because it doesn't have to be. Also, because it doesn't have to be a million degrees below zero, right?
Yeah. Well, and also you get that 30-day window instead of the 5-day window to use it. So it is a little bit more user-friendly vaccine, and so but that would be the distribution plan. Is the federal government will do direct shipment and direct delivery to different locations, and then if it has to be broken down further, then that would be distributed from the Department of Health.
Dirk, this is Dwayne. So the thermal resilience of the Moderna is really hopeful for distribution to the outlying communities. I'm assuming that a lot of this distribution process is going then through Tim and the warehouses. And with regard to the number of doses, it's my understanding that it takes a follow-up booster. And so the numbers that are being reported actually should probably be considered maybe halved in terms of.
No.
Okay.
And so when we're talking doses, and when I'm talking doses, I'm talking people. You are making a good point that when we say the 6,825 doses, that would be for one person, but then there'd be a follow-up allocation that would come 3 weeks later that we would also receive. That's already kind of earmarked to be sent out from the federal government. So they may have, I would say they'd have 40 million doses that would treat 20 million people. But when I'm talking doses, I'm talking direct people. And so that's, I guess, how I'd phrase it.
Thank you for the clarity. Any other questions over the current COVID response?
Chairman Poole, this is Daryl Birch. Just a question for Dirk. I noticed that the number of tests that are done being reported daily has decreased a lot. Can you just tell us what the reasoning is why there are less tests being recorded now?
Well, I say it's a multitude of factors. And I guess the first factor is, are we doing less testing events? The answer is no, we are not. And it's just, if we do a testing event, we may have traditionally gotten 500 people. Well, the past couple of weeks, maybe 250 individuals would have shown up to that testing event. So we are having just a demand decrease that's happening statewide. We are also instituting several pilot projects in multiple lines of effort for rapid tests, known as Buy Next Now. I think you'll hear the governor talk about that at the press conference today. And so we do have pilot projects happening at K through 12. We're working with the university system. We're working with medical providers, businesses, the community. And so we are developing a significant, robust rapid testing program that would be antigen testing. And that is not, when you're seeing the numbers of 3,800 tests, that's not counting those antigen tests. That's just the PCR tests that you may be seeing. And so I know that we probably had another 1,700 antigen tests in addition to the 3,800 tests. So I would say that, is testing going down? I would agree that that's probably happening from a demand side. We are figuring out ways to maybe utilize different testing mechanisms and methodology, and then we just need to relay to the public and communicate to the public that just because you're seeing the PCR testing goes down, our antigen testing is also coming up. And so we just probably have to do a better job of communicating that in total, we're still doing a significant amount of testing. I mean, we're still 1-2 in per capita in terms of testing. And I know our testing team is working around the clock just to make sure that people are continuing to get tested. The other thing that's probably having an impact is our long-term care facilities positivity rates have been decreasing. And so some of them will start falling off, having to do twice a week testing. They would shift to once a week testing. And that is 60% of the PCR testing that we had been doing. So multiple factors.
A drop off in testing is not necessarily a bad thing, given that a lot of testing is motivated by potential or known exposures, or symptomology is driving people to go in and participate in the testing lines. And you also have the feedback as well that the positivity rate is also dropping.
I would say that
time.
Yeah, I would challenge that, Chairman Poole. I would say that that's a dangerous line of thinking, especially with the amount of asymptomatic spread that happens with this disease. We want to make sure that people understand that that's really how the disease spreads is people who feel like they're feeling good. They don't even know they have the disease. And then they take that to a Christmas gathering or a holiday gathering. So what we really want to do is encourage testing, whether it's antigen testing or PCR testing. We want to keep encouraging that because that's the quickest way to isolate people out of the community if they're positive. And so we want to keep pushing that message and pushing that responsibility, because things are looking good, but that doesn't mean that's the time to drop your guard. That's probably the time to say, hey, what can we do to make sure that it remains good so we don't have that second wave? And so we allow the vaccines to come into our system and then, build up our numbers so we get to a point where we can find our way out. And so we can't stop testing. It's
Thank you.
a keystone of everything we do.
Yeah, point taken. And I didn't mean to belittle the concept of testing. I was mostly focusing on the reasons why most people have tended to go there. But I think you raise a very good point, which is, the asymptomatic nature is still disconcerting. And how do you increase participation rate then in the testing if people tend to be motivated by symptomology or known exposure?
Yeah, we think that we're working on a couple different avenues. One is just people I believe in North Dakota want to do the right thing, right? And they want to do the good thing. And so before Christmas, I think you're going to see a push just to make sure that people get tested before they go home, because nobody wants to go to their Christmas dinner with their family and be the one that is positive and infects their family. Nobody wants that to happen. So you'll see a push in terms of that way. I think the rapid testing will help entice people to do testing, because then the results happen as soon as 15 minutes. And I think that's a big selling point for a lot of people. So we are navigating multiple ways to kind of get at this. And then we're also working directly with certain communities, which, I mean, if you're working with the business community, you're working with the schools, you're working with the university systems, you're working with the first responders, you're getting a good slice of the community that way too, if you're just doing direct testing with specific populations.
I really appreciate everything that you're doing, and I really appreciate you correcting the message that was coming from me. I absolutely appreciate that.
Chairman Poole, I have a question for Dirk. This is Jenny. Actually, first a comment in regards to the messaging. When you were saying getting messages out to the public, I've seen the commercials as well as the messaging via Facebook and the like. Well done. Whoever you're working with in regards to getting that messaging out, I think that whole shift in how you provide messaging of, caring for your neighbors and doing the North Dakota right thing, it's great. I thought the change in messaging has been phenomenal. One question I did have is I heard the rapid tests are not as accurate as far as rates, and I just wanted to get clarification. Do you know what the accuracy rate is of those rapid tests?
And so I think it would vary depending on who you talk to. So I think there is a community of individuals and doctors that would say that it better identifies who is infectious and who has a higher viral load. I would say that there's another community that says it's not as precise, and that you may miss some people that would be marked positive. And so there's probably a mixed messages there. I would say that if you get a positive test from an antigen test, especially the Binax test, that's a positive. That is very, very specific and works very well. There is probably a dip, I would say, in terms of what would be known as a positive in a PCR test, which might be people who are, how it's been described to me is there's a bell curve, right? And so, because I'm not a lab person, I'll explain it the way that I understand it. So there's a bell curve. The antigen test is really good at getting that top part of that bell. And then the PCR is really good at getting this bottom part of the bell in addition to the top part. And so these portions of that bell curve are probably better identified through PCR. And then this might be identifying what's more infectious and more has a higher viral load. At least that's the theory that's been presented. And in our meeting with the CDC director on Friday, he was a strong advocate for these tests.
Okay. Is there anything else on COVID response so we can continue moving? The last topic I was going to have was testing, and so I think we hit it. So I'm good to go unless there's any additional questions. Thank you. Hearing none, let's move on to the possible legislation for 2021. Are there any legislative agendas or items we need to address or need to be addressed by this committee to move forward to the legislative session? Brenda or Dirk?
I am not aware of any additional legislative items that need to be added.
Yeah, I wonder if it was just the ones that were part of Bobby's presentation.
I think that was what it was. All right. We have an item regarding long-term care issues. Commissioner Roars is going to take the lead on this one.
Yeah, so I guess I have people who have just asked some questions about what is the status of the investigation process in long-term care with allegations of abuse and neglect, some concerns that maybe, sorry, there's some feedback, that maybe they're not.
Please mute your microphones, people. It sounds like somebody has it on two different devices.
I did. Okay. All right. I just did that.
Okay. Awesome. Thank you. Yay. No
Sorry,
more echo.
Kristen.
Okay. No worries. Thank you. And so just some concerns about what is the process, especially as we've been trying to limit the number of people going into long-term care, but also because we don't have families in there, the risk feels higher because there's not that opportunity for them to really be able to visualize their loved ones. So I would like to hear just an update of where we're at with that.
Hi, this is Bridget Widener. I'm the Division Director for the Division of Health Facilities, and we have responsibilities to survey long-term care. And I have Kathy Laxdal with me. She's the Program Manager for Long-Term Care as well. So we are currently following CMS's guidance regarding surveys in long-term care. We have, between our office, the federal surveyors and the federal contracted surveys, actually done 180 focus infection control surveys, approximately 180 since April. So we are definitely getting into the facilities. What has been different is the focus. They're not recertification surveys where we're spending the whole week there looking at everything like we normally do. They've been focused on infection control per CMS's guidance. When you specifically address abuse and neglect concerns, our office is still taking complaints, and we do get a high volume of complaints. A lot of them have related to visitation issues or things like that. Specifically to abuse and neglect, we did do a little bit of a data poll, and abuse and neglect was cited once in fiscal year 19, and our fiscal years run October 1st through September 30th. One citation in fiscal year 20, and since October 1st of this year, we've cited 2 abuse-related deficiencies. So when we do get these concerns and complaints in a nursing home, we have a triage process where we prioritize the severity of the complaint. If it is a true abuse and neglect complaint that would rise to a high prioritization level, we send a team there immediately. We would call that immediate jeopardy prioritization, and we have a team on site within 2 days. Not a lot of our complaints have jumped to that level of prioritization. So I would say we're not really seeing a whole lot of a spike or increase in our abuse and neglect complaints or citations. And Kathy, do you have anything specific to add from your standpoint?
Kathy, you're on mute.
regarding being able to go into the facilities, our surveyors wear PPE, are well versed in using PPE and doing infection control prevention measures while they're in the facilities. So we are able to go in and do complaint investigations. And also, as Bridget said, do our focused infection control surveys. And during those surveys, we do interview residents and staff. We observe them donning and doffing PPE, use of hand hygiene, policies and procedures. Are they appropriately cohorting those that are positive for COVID and those type of things? So they're in the building. One survey, we send 2 surveyors, and we're probably in the building between right around an average of 5 to 6 hours. So
yeah, and when we're there also, even though our focus is on the infection control of the facility, our surveyors are well versed in the survey process, and if they see anything that is a concern or would trigger a possible abuse, neglect type of situation, all they have to do is contact our office, and then they have authorization to follow that, because that's what we're there for. We are the eyes and the ears in those facilities right now from a regulatory perspective. So if they would see anything beyond infection control that really was a high level of concern to them, they would definitely be able to follow up and do more investigation related to those concerns as well.
So this is Dwayne Poole. What's the mechanism for engagement for those people? I mean, one of the questions or complaints that I've received is they can't find a form to fill out. They don't know how to make contact. Those are some of the issues that I hear about. And so I'm wondering, through the Department of Health, what's the actual process for the loved one who has an issue?
Kathy, I think it's a requirement that they provide our contact information. So we do not have a specific form because we really don't want to limit how a family member or a resident can contact us. So we take phone calls, a lot of them. A bulk of our day is on the phone with concerned citizens. We accept mail, we receive letters, we accept faxes, we accept emails. We also have an email specifically for long-term care concerns. So there's also in person. We have not so much during COVID, but in the past, we also accept walk-ins. So there's really no limit to the mechanism. Mr. Poole, they have whatever avenue they want to ensure that their concerns. We also have an ombudsman program. It's not the health department's program, but it's through the Department of Human Services, and that's another avenue. And then the Vulnerable Adult Protective Services has a reporting mechanism, and if it's specific to a facility, that information is forwarded to our office.
So then how does the citizen looking for that phone number, email, or whatever, how do they find that phone number or email?
It's a regulation that every facility, though during this time, the families are probably not in the facility, but every facility has to have that posted in their building, the contact information. Also on our website, I believe the long-term care concern link is on our website.
So I would just challenge you that, especially during these times, because people aren't physically there to see that posting, that I think we need to find some sort of proactive way, whether we work with the Long-Term Care Association or whatever it is, to try and figure out, not that you want to be flooded with more calls than you already have, but what is the alternative to a physical posting when we are not allowing families in to actually be in the physical building? And so just trying to think creatively and think outside the box of how is that communicated with the families? Is it something where we want facilities to just have it posted on their website somewhere so that people can find that if they do have a complaint, something to that effect? I think just to try and think through that. One question I have as follow-up is, so aside from like the infection control surveys, and I understand once you're there, if you see something, you do something. But how would you say your process is different from, let's say, last fiscal year to this fiscal year, when it comes to kind of, let's just stay in the realm of abuse and neglect? Would you say that you are doing as many investigations, less investigations, not just the volume coming in, but kind of once they've been elevated to the level of saying, yep, this is something we need to look into? Would you say, are you doing more of it virtually? I just am trying to understand the process and what has changed this year.
We are doing no surveys virtually. All surveys and all programs are physically on site, doing observations of the care provided, interviews of residents and staff, and record review. We probably have done less on-site complaints per se because our focus has been, per CMS, the focus infection control surveys. However, if they were an immediate jeopardy complaint or a non-immediate jeopardy high, those really high concern complaints, those we have changed our process. Not at all. We have authorization from day one. Our survey process was halted in March. We were actually at facilities when CMS called all the survey activity off. But the one thing they have been very, very clear on is immediate jeopardy complaints or any of those high priority complaints must continue as we always have. So that process for the severe complaints has not changed.
I guess my own personal curiosity, just as you've had conversations with CMS, just with the fact that you said that the vast majority of the calls that you get have to do with visitation, have they been open to conversation about visitation and relaxing their memo or anything? Have you heard any signs of hope?
They've been very, very open to conversation. We've had lots of conversation with CMS, including the decision makers from CMS from the survey and certification perspective. And we've also looped in our congressional delegation representatives. So we have had a lot of conversations. In fact, our state had been more open to visitation than a lot of other states. So when the CMS memo came out, the QSO 2039 memo came out in September, our state actually felt it restricted visitation beyond what other states had allowed. And CMS has been very, very clear that the intent of the memo was to require visitation as long as certain parameters were met, and that being one, the county positivity rate. Well, right in September, October, November, we all know what happened to our positivity rates across the counties. They spiked. So if the county positivity rate was greater than 10%, there was no visitation. So that really took out visitation for the majority of our counties. On top of the county positivity rate, CMS has indicated if they have one positive staff or one positive resident or are in outbreak testing, so basically a period of 2 weeks, if there's been any positives, you can't have visitors inside. The whole time we've been allowed to have outdoor visitation. So our biggest issue has been indoor, and we have pleaded with them. I think that one of the times we had one of our calls, it was October, and it was snowing, and it was very, very cold. And we're like, it's really not a realistic concept right now to
gladly
have
invite them
visitors
here
outdoor.
in the middle of February, right?
Yeah. So we do continue the conversations. In fact, we had a meeting yesterday with the VP3 group and a representative from the governor's office, and we submitted more questions to CMS because we do see the importance of visitation for the psychosocial well-being of our residents. but also realizing there has to be a balance with the infection control component. So they have been very, very open to the conversations. We just haven't necessarily gotten the answer that we want, but we definitely have been asking the questions, and they've been receptive to the conversations. And again, they continue to say outdoor visitation is something that isn't potentially an option, and visitation is required as long as the county positivity is less than 10 and there's no positive residents and staff.
I'd just like to, if I may, make a clarification when we talk about surveys and facilities and CMS. CMS only oversees the skilled nursing facility, the 79 nursing homes. So when we talk about 180 surveys, those are just in the 79 nursing homes. CMS does not oversee the basic cares or the assisted living. Basic care is under state licensing, and assisted living is under human services.
And that's a great point, Kathy, because that also then applies to that visitation. Senator Roars, assisted living and basic care visitation is really up to our state how we want to implement that. The visitation restrictions, the memo that you're aware of in September is specific to those 79 nursing homes.
So several of the skilled facilities we have been in more than once. If you look at the number and the ratio, some of them we may have been in 4 and 5 times since April.
So at the State Health Department center there, the EPR center, can you make sure that Dr. Brousseau is off of mute, please? Okay. Dr. Brousseau, did you hear that? You're responsible for muting yourself.
Okay, can you hear me now?
Yes.
You can hear me, okay. Well, my mute button has not been on, so I've been able to hear everything and trying to participate but can't. Anyway, I just want to say a word about the inspection team from the State Health Department. And you're hearing me okay now, right?
Yes.
Okay. I was a medical nursing home medical director for 25 years. I can tell you I've had a lot of dealings with people from the State Health Department, and they're always very efficient. They're always very thorough in their responses. And no nursing home wants to be at odds with the state survey team because they face severe penalties if they are. And if there are complaints like, if there are complaints that are not addressed properly, that is a big deal for people in the nursing home business. So I do think there's goodwill and good faith and good work being done by everybody from the State Health Department. But occasionally you do run into people who continue to have complaints. And my thinking on that is that at that point, when the nursing home staff realizes that they're not meeting somebody's expectations, then the nursing home administration should invite that family member or whoever it might be to contact the State Health Department and take it up with them, and maybe not waiting for them to find the number and call it. They should actively participate in this kind of an inspection. I think that would help a lot.
I'm going to follow on to that, and that is when people have individual or specific complaints. I think the process needs to be easily accessible to that family member, and through the process, whether it goes their way or what they don't want or whatever, is not so much relevant to me, but a feeling that they had access to the process, that a process that is articulated and communicated in some way to them is out there, and that they feel that the process was conducted properly would be, I guess, what my ideal of what an appropriate process would be. And based upon the feedback that I've gotten and some of the calls that I've gotten, and I admit it's increased because of the COVID thing, access or knowing what number to call or even who to call or how to get a hold of somebody. I mean, at the point where they're reaching out to health council members or legislators, basically to me means that we as a health council have not been doing well enough in our job in making sure that the health department has an easily accessible communications mechanism and responsiveness to the public. That would be my issue here. And I'm not sure, Dirk, how we address that, but Kristen, do you think it would be worth putting together a subcommittee just to review processes and make recommendations?
Yeah, because I, based on what you guys have told me today, I don't have concerns about the actual process that we're doing. It's the perception of the process. And so what can we do to help, allay some of those fears that are out there from people that like literally what I'm being told is that there haven't been any abuse and neglect investigations being done because you're so busy with COVID. Obviously, that is not true. Obviously,
That's not true.
Oh, absolutely. And I believe you. The perception, though, is the opposite. And so how do we work on that? How do we ensure that people understand that you guys did not drop everything and everybody is 100% COVID, focused and that kind of stuff, that you are still doing the work that you are, tasked with to ensure that people are staying safe and happy and healthy in these long-term care facilities. And so what are some ways that we can help get that message out to the communities? And then also just making sure that by whatever mechanism it is, people know without having to go to the facility how to contact you in the event that they do have a concern that they want to raise.
I speak, just like to make a point off of what Dr. Brusso said. When I do get a call for a complaint or a concern, I do say to the person, have you spoken to the facility? Because it is part of the facility's responsibility to educate their staff or their families and provide them that resources and those information on admission and throughout their stay on who to contact. And there are several facilities, as Dr. Brusso pointed out, that the facility administrator, the director of nursing, whoever will say, this is the number to the health department. You can reach out to them for more follow-up.
Yeah, and I think that you have those really good administrators who say, are super proactive and say, here are those opportunities. I think that there's been a long-standing fear of any type of surveyor, whether it be, I work in a hospital, so whether it's the Joint Commission or whether it's your team coming in doing a validation survey on behalf of CMS, I'm sure that, there's always that level of fear, but then the family members also, when we do encourage them to reach out to the facility. First, one of the challenges that we have is that they have this fear of retribution. If they complain, is their family member going to be retaliated against? And they won't be there to know it and see it. And so I understand where the fears are coming from. And so my biggest concern is how do we make this the most open and welcoming process that we can, and also try to really reduce some of those fears for these family members who are already having such a tough time because they aren't able to see their loved ones every day.
Kristen, I would echo that. I think that's even a larger issue when we look at the smaller communities where there are fewer alternatives for those people to say, I'm going to move over to this other facility or move my person to this other facility. They don't really have that option. And one of the things I've heard as well is the fear of retribution or fear of other backlash in the community as a result of creating heat or issues with them. So I think it might be worth putting together a subcommittee just to review with staff, work with staff on how we communicate this, how we communicate the process. And I mean, I understand the immediate jeopardy sort of thing, but are there other investigative scales of investigation that there's process for? And I mean, kind of look at the whole picture of how responsive to the consumer. Some of the people are on Medicaid, other people are paying, $16,000 out of pocket for care for their individual loved one and have some expectation. I just want to make sure that we're representing the consumer. One of my roles.
Can I also say, excuse me, or when we do a survey, a complaint survey, when our surveyors go in the building, we never say who we're there to investigate. We have a process of where we identify the issues that we're going to look at. Then we select a sample and, do our investigation. Can I say that the facility may be able to figure out who we're looking at, but our surveyors never say we are here to investigate a concern with, and when I talk with families, which I do on a daily basis, I assure them that we are not going in there and saying we are here to investigate so-and-so's mother or that type of thing. That is not within our protocol.
Nor do the families know when we're going, because it's unannounced, 100% unannounced to everybody. The only people who know when we're going on site is us. So the families aren't informed when the survey is happening, nor are the facilities.
So, Chairman Poole, this is Daryl. I would make comment that the position of the health department is always challenging, trying to find that balance between the resident, the family, CMS regulation, and the facility. That's a challenge in every normal day. Then COVID comes along and has made these challenges even more difficult. Certainly in 20 plus years I've been an administrator in North Dakota, I've always found the health department to be keep that in mind, that balance, but always to have the residents' best interests at heart. That being said, I would certainly volunteer and be in the subcommittee of this as well.
That's what I.
One other thing I've got to add here, this is Jim speaking again. There's a medical director, a physician for each nursing home in the state, and they should be actively involved in dealing with complaints as they come up also. So, there are many ways in which the process can be addressed, I think, and they have to involve the medical director, though.
So, all right. So we have Kristen and Daryl on a committee to work with Bridget and look at the process and review the process and see if there are issues that we'd like to bring up or address on behalf of the council. Is there anybody else who wants to be on that committee?
This is Jim. I'll be on the subcommittee too if you want me on there.
All right. So Daryl, Kristen, and Jim, please follow up with Bridget. Would you please follow up with them and set something up?
Sure. I would like to start with the subcommittee being informative, because I do want to just mention that the complaint process that we use is a federal complaint process, and we have a whole, what we call a state operation manual, Chapter 5, that dictates exactly how we must handle the long-term care complaint process and the prioritization. How, getting the information out, the phone numbers of websites, that information obviously is not covered in there, but the prioritization, how we actually do the surveys, we could maybe start with getting some of that information out to the subcommittee so they have some information. We can do complaints from a state perspective, but the teeth in the long-term care survey process comes from the federal certification. So that's typically the avenue we go, and we'll be happy to get that that information out to you all as a starting point.
That would be great. Just kind of bring us all up to the same level so that then we're starting from this, a little base of knowledge. That'd be awesome.
Then it was Daryl, then Kristen, and Dr. Russo on the committee so far. Is that correct?
Correct. Yep.
Yeah. Kristen, was there anything else on this issue we needed to address?
No, thank you very much, you guys. I just, when you get concerns from the community, I'd rather bring it to the source and have that conversation rather than let that kind of fester. So thank you for bringing that information to me.
Thank you. The final item on our agenda is whether or not we might potentially want to issue at some point a letter of support for the state health department's budget request to the legislature. Dirk or Brenda, would you like to provide a little, forward into the idea of your budget? I think you presented it to us at the last meeting, and then the council, if I don't know whether we would do one single letter or just let individuals send letters in support if they feel like that needs to happen, because we know it's going to be another austere budget year. And so I know that the governor's office and others would like to see support for their executive budgets that they put forward. I know, Kristen, you're in a slightly different position.
I'm on a policy committee. I have no say. I got one vote out of 47.
There was a little item in Bobby Will's note to us that said we don't want to bring attention to the program during the session.
Yeah.
So
that's a separate budget item. This is over the overall budget for the state.
Okay. All right.
Health department. So.
I guess
extend onto this then.
Good, Dirk.
Yeah, I guess if we want to dive deeper into the budget, Linda's obviously the expert on that. I would say I think getting support for our budget is always very welcome. We are having some big asks, especially with obviously our COVID response activities. So there is some increases that's associated with that the governor presented at his governor budget briefing. So if, as a health department, we would welcome the support for our budgetary process and how it aligns, obviously, because we do think it's important that we do have the tools to continue to respond to COVID, continue to respond to this pandemic, and make sure that our citizens are safe. And we understand probably better than most that just because the first batch of vaccines got here doesn't mean that we're safe, and just because our numbers are down now doesn't mean that that's where it's going to be in a few months. And so there's a lot of work before we even get to next biennium. And so, but when we get there, I think we want to be in as good and solid position as possible, not to have to ramp back up in terms of our activity. And I think if there's one thing that we did learn through this cycle and through this response is that we were a little bit slimmer than we needed to be, and we needed more resources. So I guess we would always advocate for resources in alignment with the governor's proposal. And so if you guys wanted to provide your support, we would welcome it, but ultimately we would land on what you guys choose as individuals or as a health council. I'm not sure if Brenda has anything to add.
So I will ask the council then. Last time I wrote a letter, it was in regard to the order, and I wrote a letter and distributed it to you guys. Would you as a council like for me to work with Brenda and Dirk and craft a letter in support of the budget request, or would you prefer that I do nothing and we do it individually?
And I guess I also want to make a point that we can't really dive deep into the budget because it wasn't specifically on the agenda for today.
So
I think the
letter of support.
The letter of support. So it just sometimes there's some legal maneuvering that needs to happen. I just want to make sure that we're in alignment. But so probably can't do a full deep dive into it, but appreciate any support that we could get.
So as a matter of clarification, this does not include the human services budget, or does it include Bobby Will's loan repayment, correct?
Correct. This is the overall budget for the state health department.
Thank you.
Cody, part 2, please.
All right. So nobody wants me to write a letter. No big deal. You can, if you would like to, you can write your own. Is that the way we're thinking?
I think that's a good idea, Dwayne.
Okay. Well, then I would encourage the individual members of this council to take a look at what Brenda supplied last time and think about the tasks, responsibilities, changes in responsibilities, and public health of the state, and provide a response if you can to the governor's office and your local legislators in support of the budget. If you don't support the budget, you are free to say so as well, but I will be writing a letter for myself individually. Thank you.
Thank you.
No further business identified on the agenda, so we must end this executive session. I don't think we even need a motion to do that. It's just, I call an end to it. So thank you everybody for participating. Kristen, let's speak offline again then about the
Sounds
work
good.
group and where we're going. Thank you.
Sounds good.
Bye.
Thank you.
Okay, so on.